the aims and objectives are about knowledge, and knowledge we can divide into academic knowledge and technical knowledge, which is practical. So the academic side is theoretical. Most of us, I'm taking it, where most of us are graduated, and we know what we're talking about when it comes to pulpitis and things like that. But the technical aspect of it is going to be variable, depending on which line of dentistry you're working in. But what you need to do is combine the two, and you need to look at the wisdom aspect of combining the two together, which is actually the application of good judgment to human conduct. So it's doing the right thing at the right moment. And in this current climate, I'm not going to dwell too much on the COVID situation, but as far as the UK is concerned, we're told we're not allowed to treat anybody, and as of I think it was the 24th or 25th, we actually stopped treating people. So I think, I'm going to touch on both the academic and the technical side of things, and hopefully you'll take something away which is going to help you in your practice. Maybe not now, but after all this is over. Or if you're working in a hospital environment and you are actually still seeing patients, the majority of cases that you're going to be seeing are most likely to be the cases which are those which are either pulpitic, or they're abscessed, or they have a facial swelling. Most routine dentistry in the UK at the moment is pretty much on the back burner, which means it's on hold, where we're not really allowed to do most routine stuff. So the majority of cases that you're going to be seeing, if you are seeing patients, are going to come into this sort of category. So the factors to consider. Firstly, you need to divide it up into three. And as I said, I don't have a cursor here. So if you look at the top left-hand corner of your screen, you've got the dentist factors, you've got the patient factors, and you've got local factors. If you look at the dental factors, we'll start with that. Think about the knowledge and the skill. So depending on how far you're trained, and obviously, as I said, most of us know how to extirpate a pulp, various people are going to feel very different about whether they feel comfortable doing this kind of procedure. You have to weigh up the risk and the benefit. So the risks obviously are going to be, if you have complicated teeth, how far are you going to go with extirpating a pulp? And obviously it's got to be beneficial to the patient, because most of these patients are going to come to you in pain. Can you actually predictably get them out of pain? Not just at that moment, but for the foreseeable future as well. You have to look at the outcomes. That falls into whether you're actually going to make a successful attempt at doing this, and you're going to relieve them of their symptoms. Can you do it in a single or multiple visit? Is it something that we should be doing in one go, or is it something that you can open and dress? And again, that's going to be based on your skill set. There's a question of time and money. And in your practices, you'll find that if you're working on the NHS, I fully appreciate that time is going to be restricted, because the money aspect of it, you're not really going to be remunerated for your equipment. So that's another aspect to consider as well. Patient factors, you look at the motivation and the attitude. Some patients are going to be fearful of coming to the dentist. Some of them who are in pain, they're not going to be feeling very well. They may be irate. They're not going to be listening to you. They're only thinking about themselves. So if you put yourself in the patient's shoes, you'll find that it can be actually very difficult for them to appreciate what you're trying to do for them. The medical history, obviously, you have to check that. Off the top of my head, I'll just say something like, for example, if they're on bisphosphonates, that might affect your decision, but you must consider the medical history as well. And again, the cost benefit to the patient, is keeping the tooth something that's cost effective for that particular individual? So you have to look at their social history as well and say, look, is this going to be right for you? Because depending on how much something like this will cost, is a discussion that you have to have for them. And is it going to be beneficial for them? I.e., is this tooth worth saving? The time it takes for the patient as well. Very often these patients are not going to be booked in. They're going to come to you as an emergency. So you're either going to book them in at the end of a lunch period, or the beginning of a lunch period, or the end of the day, at which point you're tired, you're hungry in both situations. And have you got enough time to manage a condition like this? Again, that's something that you have to consider on the patient factors. Then you look at the local factors. Once you actually look at the patient, have they got enough mouth opening? Can you get in there? Where is the tooth? Is it far back? Is it somewhere where you can't actually get to? These are things that you need to look at. And again, looking at the tooth anatomy, and we'll come onto these aspects as well. Look at the surgery and the equipment. Are you equipped to do this procedure? What type of practice are you working on? Or are you working in a hospital environment where you have open clinics? You know, you're going to have certain patients who are screaming. You know, when you actually go in, is the environment conducive to you doing this kind of treatment? So these are the things that you need to look at. On the note of the surgery, this is where I work. I'm a private practitioner in Wimbledon, so my practice is limited to endodontics. And this is the surgery that I put together myself after having worked in a number of different environments, both in mixed practices as well as in hospital environments and in private practices as well. And I was always disappointed with the actual equipment and the settings that I was provided with. So I got fed up, threw everything out the window and said, right, I'll do it my way. So I set up and designed this surgery, which is in Wimbledon. And you can see that we have a nice, comfortable environment. That's our waiting room. We have one patient in there every 2 hours. You can see my surgery. It's well equipped with a microscope, and it's relatively simple, but it's ergonomically designed, which is then something that I thought of quite carefully when I looked at various different practices and thought, I'm not feeling comfortable working where I am. So you have to, again, the dentist factor and the patient factor. And this is something I designed for my staff as well. So it is something to consider. You have to be comfortable in your environment, and you'll never do your best work until you feel comfortable in your environment. Otherwise, it's always going to be a compromise. The cost. Obviously, I won't go too much into this, but depending on where you practice, whether it's NHS or private or in the hospital, you have to consider, what does it cost to do this particular procedure? Is it worth it? Okay, for both yourself and for both your patient. So you have to be fair on both sides. I'm not going to dwell too much on it, but people who think that they work in the hospital think, it's all free. Somebody has to pay for it. So I'm not going to dwell too much on that. I've been in hospitals where I've had to debate on this and say, listen, the taxpayer is paying for this. It's not a free service. So you have to make sure that you feel comfortable and you feel happy doing the work for the cost that you're going to be charging. Let's get into it. I'm going to whisk through this. This is the way I look at teeth. Okay, so when somebody comes to you and they are in pain, the first thing you're going to look at is the restorability of the tooth. Okay, and I say the first thing after all those factors are considered. When you look at the tooth, you have to break it down into the periodontal factors, the prosthodontic, and the endodontic factors. Periodontic, obviously, I'm not going to dwell too much on this, but you need to look at the oral hygiene. Is there any bone loss? The recession? Mobility, is the tooth mobile? Again, this is going to sort of may swing your opinion as to whether it's actually worth embarking on this procedure or not. Look for pockets. Are there any perioendo lesions there? And again, pockets are something that may indicate fractures as well. So, do probe around there. So look at the periodontal status of the tooth. The next thing to consider is the prosthodontic factors. And if you look at the top left-hand corner, the remaining dentition is very important, as well as the occlusion. Those are the two main things that I will look at when a patient comes to me. So look at how many teeth they've got left. How does that tooth fit into the big picture? Okay. Look at the occlusion. Are there any non-working side interferences? Is there anything that you think could lead to the failure or the outcome? As I said, when you're assessing the outcome, have a look and think, right, is there anything in the occlusion that I think is that could potentially be causing A, the problem, or B, is going to affect the outcome? If you look at the bottom left-hand corner, look at the remaining dentine. When you look at the particular tooth, you'll consider the remaining dentine. Look, you're normally going to put a crown on this tooth, so look at the retention requirements. Check crown-root ratio on the radiograph. Check the biological width. Can you predictably place a crown and predictably restore the tooth? Is it a bridge abutment? Okay, again, these are factors that might affect your outcome. Can you predictably cut through a bridge and see what you're doing? Do you have the facility and the equipment to do that? Consider whether, even if it's part of a tooth that's left, as I said, if somebody's on their medical history is such that they require bisphosphonates and you may want to just preserve part of the tooth and avoid extraction, you may consider an overdenture abutment. So again, think about it in those three terms, and then look at the endodontic component. I'm not going to dwell too much on the rest of this because that's not really applicable. I picked out some of these slides just from previous presentations, but is the tooth obviously vital? We're talking about a pulpitis here, so the rest of it really doesn't apply, apart from the bottom left-hand corner, which is the canal anatomy. Have a look at the tooth, the length, the curvatures, sclerosis or resorption. These factors are things that you need to consider before you actually put your burr to your tooth. Looking at the tooth factors, complex cases. You must be able to recognize complex cases. You know, be wary of starting on the top left, long roots for canine, you know, for canines, or even sometimes you can have lower sevens with long roots. Upper and lower sevens and eights, access-wise, they're very difficult to do. Upper premolars, there's not much latitude in drilling into a premolar pulp. You know, the roots are actually flattened mesiodistally, so there's not much room for error, particularly under crowns. Lower incisors, classically, these are not simple teeth to do. They can be very, very complicated. Again, there's not much latitude when it comes to accessing these teeth. When it comes to when you look at the actual, again, the mesiodistal aspect of the tooth, it's very flattened. The root's very flattened. You know, so you really have to keep things minimal, as well as preps should be kept minimal in these situations. Look for canal sclerosis on the bottom right-hand side. Canal sclerosis, pulp stones. You know, normally you can have complete pulp canal obliteration. You know, with trauma in some of these upper central incisors, they will be completely obliterated. You know, are you going to do any justice by trying to go in there if you can't see what you're doing? If you look at the bottom left-hand side, acute and multiplanar curves, these are things that you need to consider. Have you got the skill and the ability to negotiate these? And again, this lecture is not, I'm not here to try to teach you or advise you how to negotiate those. Those are for other lectures if you're interested. So let's look at a tooth here. This is a typical case, came in, recently fitted crown. And what you can see here is that it was a lower 7. It has got some pulp sclerosis. If you look carefully, you'll see those little white flecks in the pulp chamber. The root's actually quite flattened mesiodistally, so there's not much room for error as far as prepping the tooth. They are long roots as well, and you will have slight curves at the bottom as well. Again, this is a vital case, but even then you can see that there appears to be some apical breakdown there as well. So, you know, you're not really sure, is it a necrotic case, partially necrotic, is it vital? But this patient presented with pain following the placement of that crown. Okay, so if I show you the post-op there, that's just showing you that it's actually quite complicated as far as the apical curves are concerned, you know, and with these vital cases, you know, you have vital pulp tissue in that tooth, which if you pack down with collagen, sometimes you can block yourself out and it can be very difficult. Again, cutting through crowns, it's up to you whether you feel comfortable doing such work, especially with a newly placed crown. You want to try and keep the prep quite minimal if you're not to replace the crown, at least for that sort of interim period. Again, another case here looks like a short root, very easy. Looks very straightforward. If I don't have my cursor, but if you look carefully on the mesial aspect of this upper right 6, you'll see that there is quite a deep filling and it's close to the pulp. And if you actually look inside the pulp chamber, you can see that there's some sclerotic dentine there as well, or some form of sclerosis there as well. Don't be fooled by the short root, the mesial root. Although it's short, these kind of things can really block you out quite quickly if you pack that pulp tissue down there. So when you do extirpate, just be careful that you use plenty of things like Glide and plenty of irrigation to make sure that you don't block yourself out. So this is the actual case that's completed. It's pretty straightforward as far as endo is concerned. It's not, you know, this is humdrum stuff that I do on a daily basis. But this is what I saw inside. So as you go into the tooth, once you've accessed it, you can see that there are pulp stones there, and these need to be removed. If you can't see this, or if you can't see this accurately, then you might end up pushing one of these stones further down into the canal, and again, you're going to block yourself out. What you can see there is, you can see that it's a degenerative pulp as well. So the actual pulp can appear in different forms depending on the state of inflammation. So I will go through some of the various things that you can expect to see in degenerative pulps or pulpitic teeth. But once you've cleaned it up, then you have a much better chance of getting down the canals. So if you keep if you examine the X-ray carefully to start with, that will really make sure, bless you, that will really make sure that you know, you minimize your risk of either perforating or not finding a canal, and various other complications that you can have when you're treating these teeth. Let's talk about the healthy pulp. Okay, so normally this slide I'd like to show, because both these people are healthy. The one on the left-hand side is a Japanese chap. He basically was 115 when he died, but he was perfectly healthy. The guy on the right, obviously most of you know, is Usain Bolt, who's actually a very healthy athlete. Both of them are considered healthy. But if you told both of these to do, like, say, for example, a 500-meter sprint, the chances are that our friend Mr. Kimaru, he wouldn't make it. So you have to consider the age as well, not just of the person, but of the pulp as well. So as pulps get older and older, they do degenerate to some degree. So that's another factor to consider. So when you're looking at the tooth history, as I said, first thing you would consider is, okay, how old is this patient? So if somebody turns up and they're 70-year-old and they've got, a sclerosed pulp, you would think you should take that into consideration. Look at the replacement restorations. How many times has this, asked the question to the patient, how many times has the restoration been replaced? Is it a timing of any restoration? Is it a recent restoration? Did you have it done quite recently? Every time you go into a tooth and you cut into dentine, you are causing pulpal inflammation. If you look on the right, the various types of trauma that this pulp is getting, mechanical, physical, chemical, thermal, bacterial, every time you cut a tooth, you're definitely mechanically and physically insulting that pulp. When you apply your materials, your etch bond, you're causing an irritation to the pulp. That's another form of trauma. That's chemical trauma. Thermal trauma, when you're heating up when you're cutting dentine, the pulp will heat up unless you're using, obviously most of us use water-cooled handpieces, but there are studies to show that, the minute that water is not cooling, i.e. it's switched off or it's not really pointing at that burr, you are heating that pulp up and you are getting an inflammatory response quite rapidly. So that's the thermal insult, as well as the fact that when you're cooling with a 3-in-1, all these things are actually causing thermal irritation to the pulp. Obviously, bacterial irritation. Is there a large carious lesion there? So again, it's been insulted by bacteria. And the last little one is a distinction point in an essay. It's a barometric trauma. So barometric trauma, you'll find that in patients like divers, pilots, people who dive a lot, actually, you can get this barometric trauma. And again, there are papers to show that this actually can insult the pulp as well. And I've had many professional divers, some who work sort of very deep and at base of oil rigs, which I've had to ground and say, listen, you've got a toothache. Your profession is such that you cannot afford to go to work unless you get something done about it. So anyway, that's a minor distinction point. So all these procedures, this is the way you need to think about it. All these procedures that you're doing and have been done in the past are actually hammering this pulp. So you are compromising it to some degree, and you don't know which punch it is that's going to take this pulp out. And it could be, and more often the case is, that when you place your crown on it, and someone had said, oh, I had a cracked tooth syndrome, I had some sensitivity. You place your crown. We've all experienced, and I experience this quite routinely on a weekly basis in my practice, where the patient is saying, I am now having acute toothache. I cannot sleep at night since this crown was put on. So do consider that, what you're doing to the pulp. Typical case in point here, this was a prep done by a practitioner for cracked tooth syndrome. Actually, you can see there's not much of a filling there. It's quite shallow, but again, the patient presented with acute pulpitis. And so in this temporary stage, we decided, right, let's just get this root canal done, and then you can safely put your crown on, and predictably, you'll know that you're not really likely to have much in the way of problems with this afterwards. This is another big debate, and we've had a little bit of banter on the WhatsApp chat regarding these kind of cases as well. So again, this would make further interesting debate on the stressed pulp. So we're talking about pain. When somebody comes to you, the first thing you need to do is make sure you make a correct diagnosis. Yeah, you want to make sure that this is odontogenic pain that you're dealing with. There are various things that may make you think, right, this might not be non-odontogenic. There might be musculoskeletal issues and sinus issues or other things like that. But make sure you've made a correct diagnosis. Very often these cases will come with referred pain as well. When you have an acutely pulpitic tooth, depending on the state of that pulp, which we'll come on to, and we can't actually exactly tell you, right, yes, or we can't exactly predict this is at this stage. You can have referred pain, and classically the referred pain from the lower jaw will go up towards the ear, and the upper jaw pain will actually go up the side of the face, up to the eye. And again, sometimes you can have lower jaw pain referred to the upper jaw and vice versa as well. It never crosses the midline. But the tip I'd tell you here is that if somebody comes and you say, right, this is odontogenic, they are having referred pain, ask them, where did the pain start? Where does it initially start? That will just give you some indication as to which arch you're looking at. And there are various other techniques you can do with anesthetics as well, to sort of eliminate whether it's upper or lower arch. Even you can do an individual tooth by tooth assessment as well. This is what's going on in the pulp. My mic here. So this is what's going on in the pulp. So you have a vicious cycle of pulpal inflammation. You know, the minute you get irritation, if you look at the top of the diagram here, the irritation will cause a localized response, which leads to inflammation. It leads to vascular dilatation, fluid leakage, localized increase in tissue pressure. And so there's a localized effect where you have venous collapse, reduced blood flow, accumulation of waste products. That then extends throughout the pulp, where you can get a wider zone of increased tissue pressure, ischemia. At that point, it could turn irreversible. So this concept of reversible to irreversible is a very fine line, and you can't tell exactly when it's going to go. Just like, as we said, in that boxing ring, you don't know which punch it is that's going to take that pulp out. So as that cycle progresses, you get release of enzymes, certain enzymes, you get collagenous destruction, you get larger volumes of tissue destruction. You could exit at that point, or it could actually then start to heal. But again, the whole pulp physiology aspect of it is something that we could talk about for a long time. So I don't want to dwell too much, but just have this picture in your mind. At any stage, you can find that pulp can turn from a reversible situation to an irreversible situation. What can you do to try and find out, is it reversible or is it irreversible? Right, so the first thing when somebody comes in, once you've done all your initial assessment and everything, you'll percuss the tooth. You'll say, okay, is it tender to percussion? Very often you will find that it will be tender to percussion, but there are occasions where you'll tap all the teeth in the arch and you'll think, well, there's nothing there at that time, but they'll say, I haven't slept all night. So that can be positive, it can be negative, okay? Palpation, if you palpate the soft tissues, very often you're not really in a pulpitic situation going to get much of a response. But occasionally you can, because if it is turning slightly necrotic, or you have a partially necrotic pulp, you can get some form of discomfort on palpating the gum as well, either palatally, buccally, or lingually. Thermal tests, you know, you can certainly place some cotton wool, and sometimes they'll jump out of their skin, and you'll know that, yes, that's correct. They'll have a hypersensitive response, or you'll find that they will have no response whatsoever. So again, they're not that accurate, but you know, you can use them as a guide. The main key thing with the thermal test is that if when you remove the stimulus, the pain subsides pretty much instantly, then it's most likely to be reversible. But if it lingers, then I would be more inclined to say that, yes, this seems like it's going into an irreversible situation. You can do electrical tests as well, which will stimulate the tooth, and they might have some sensitivity in the tooth, or they may give you a response, and or they may not. But again, it's not something that I would do routinely on something like that, because most of my diagnosis will actually come from percussion and the thermal test. You can also do a selective local anesthetic as well, which means that you can either individually, if it's an upper arch, you can individually isolate each tooth, numb it up, see if the pain subsides, if they are actually presenting in pain. Sometimes you can give a lower block if it's referred pain to the upper or lower jaw. Depending on which jaw it is, you can either give a block or you can give individual anesthetic to eliminate if the pain goes away, and then that will clarify which arch we're dealing with. So the hot pulp. So when these patients come to you with a hot pulp, they haven't slept all night. So I'm gonna talk a little bit about managing this, because this is going to be the main problem if they allow us to work. You know, this is going to be one of the main problems that we're going to be dealing with here. So we'll talk a little bit about this. Most of the patients that come to you with a hot pulp, they're tired, they've not had much sleep, you know, they haven't slept for maybe 3 or 4 nights. They've been in constant pain. They've had analgesics which are not working. They're exhausted. They haven't eaten. Some of them may be drinking. Sometimes, you'll find that they have cold water will actually relieve their symptoms. So they've been drinking gallons of water, and they're almost in this situation where they're in hypervolemic shock. So, they come to you, and as I said, the time factor, you may be just booking them in for 10 minutes at the end of the lunch hour, at the beginning of the lunch hour or the end of the day, and you go in there, and we've all experienced this, but you'll say, don't worry, I'll get you out of pain, you numb them up, and the minute you put the tooth to the burr to the tooth, they jump out of their skin. They frighten both you and your nurse. Your nurse takes the mask off. Mr. Faulty, I don't work for you anymore. Everyone's stressed out. Okay, so this kind of situation is no good to you. You will go home stressed out. I see I can have a day of hot pulps. Okay, so there is a lot of pressure. If you don't handle this sort of situation correctly, you will go home looking like the patient when you touch them with the burr. So local anesthesia is key. You need to make sure that you're proficient at your blocks. And the way I normally do it is like, if it's an upper tooth, you'll normally do an infiltration. If it's a lower tooth, obviously you'll do a block. But again, with the inflamed pulp, you can actually find that the blocks don't work, and many people will have experienced this, or your infiltrations don't work. So consider doing regional blocks, where you'll block the nerve further back, where the actual, I won't go into the entire physiology of it, but normally it's related to the pH of the inflamed tissue. Which when a tooth is in the inflamed, when a nerve is in the inflamed state, the pH has dropped. So there aren't many there's not enough free anesthesia there. So if you give a block further back, like for example, if it's a lower tooth, and that's where you'll normally have this kind of problem, you can give what's called a Gao-Gates block. You block it slightly further back. And if you're not familiar with those kind of injections, that you should start learning to do those. Again, infiltrations, normally you do those in the upper arch, but again, intraligamental ones are ones that I would normally go to next if I found that this is not really working. My regional block, my infiltration is not working, you can give an intraligamental. And finally, I would give an intrapulpal. That's in an extreme situation. If I really can't get somebody numb, then an intrapulpal is the only way to do it, and that hurts without a doubt. You have to tell the patient this is not going to be comfortable, and you have to inject straight into the pulp chamber. And it doesn't matter what you inject. It's pressure anesthesia that you're looking at here. So, that's what's good. That's what's going to work. But the main thing you need to make sure is that you give enough time for the anesthetic to work. And that's where most people go wrong. So sometimes if you know that somebody's coming in with a pulpitic tooth, you may want to say to them, come in an hour before and I'll give you the anesthetic. So it gives enough time for the anesthetic to work. Normally, the anesthetic that I would use is lignocaine hydrochloride, so 2% with 180,000 adrenaline. That's my standard go-to anesthetic. Articaine is I would do a supplemental. More often than not, I use it as an infiltration, or I'll use it as a Gao-Gates block in the lower arch, and that's normally adequate. Occasionally I will use bupivacaine as well, because there are some studies to show that in the inflamed nerve that can actually be a little bit more effective. But my main thing is time. Give it time. It will actually work if you give it enough time. And failing that, your only option is really to give an intrapulpal. And the way to give an intrapulpal is to make sure that you can, as I said, it's pressure anesthesia. So the last thing you want to do is open the entire lid of the pulp chamber while they're in pain and then inject. Make a small little hole and make sure you've got enough pressure pushed into that pulp chamber cavity, and you only need a small amount of solution. You don't have to blow a whole syringe on this. Half a mil, even less than half a mil will do it. It will just take a few seconds. It will pinch a little bit, and then you've got a good 10-15 minutes to get in there and remove the rest of the pulp. So if we look at primary treatment, how are we doing for time? Are we okay for time? I hope we're okay for time. I've not too long now. So primary treatment.
Take your time, Asim.
Is it okay? Yeah. Okay.
Yeah,
so
go ahead, please.
So I know it's Sunday evening, but primary treatment. So most of these cases that come, caries removal is obvious. A lot of the cases are going to be either carious or they're going to be cracked teeth. These are the most common causes that cause the pulpitis. So the first thing you want to do is make sure you remove the caries, or if it's if there's an unrestored tooth, you know, explore the cracks, see how far they go, okay? And then you need to decide, am I going to do a pulpotomy or am I going to do a pulpectomy? Obviously, the difference being, am I going to just remove part of the pulp, or do I actually go and remove the entire pulp? And that, again, is a debatable subject, because depending on your skill level, you may opt just to do a pulpotomy. You can actually technically get them out of pain with that. So if you just take a little pulp horn off, put some leather mix on a cotton wool pledget, stick it in the cavity, seal it off, send them away. Again, that's one of the strategies for a hot pulp. You know, if you don't want to go in there giving intrapulpals, the safest thing to do is say, listen, if time's a factor, if you can't get them numb, go for the pulpotomy approach in the short term with a view to definitive treatment with a pulpectomy later on when things have calmed down. And that's sometimes the best approach. More often than not, I will go for the full pulpectomy. In my hands, that's the way we do things. Yeah, so you need to decide based on your skill set and you know, what works in your hands and given your time as well. Make sure you don't traumatize a patient though, because once you traumatize a patient, that's it. You know, they're mentally, psychologically, you've messed them up as well as wrecked your day, and it's going to make life difficult for them. The other thing to do is occlusal adjustments. After whatever you've done with respect to pulpotomy or pulpectomy, make sure you reduce the occlusion, because for two reasons. One, if you're dealing with cracks, you don't want the cracks to propagate. So make sure you take it out of the bite. And secondly, and more importantly, if you have a pulp where you've taken if you have a nerve where you've removed it or partly removed it, the last thing you want to do is continually still hammer it with the occlusion. If you have an inflamed situation and you keep if you say, for example, you have an inflamed thumb and you keep smacking it, it's not going to settle down. So make sure you take it out of the occlusion. Again, a lot of this is backed up with evidence as well. There are studies, but I'm not going to hammer you with lots and lots of studies, but there are studies to show that that's actually very effective. So caries removal, explore cracks, pulpotomy or pulpectomy, and then carry out an occlusal adjustment. The procedure. So preoperatively, analgesics. Sometimes you can, if you know they're coming in, you can say, listen, take preoperative analgesia, okay? 600 milligrams of ibuprofen, if you can take ibuprofen. If not, take acetaminophen or paracetamol. You can sometimes ask them to take a sedative if they're anxious. You can say, you know, you may want to take some temazepam or something like that could help just calm them down a little bit. Local anesthetic, as I've already said before, give it time to work. So if you know that you don't have enough time, then consider carefully saying, shall we book this in to make sure we have enough time to give the anesthetic? Intraoperatively, obviously, this is pretty straightforward. Most of us know how to do this. Get your dam on there, access the tooth. If they start to feel sensitive when it comes to the dentine, you haven't given enough time to the anesthetic, and you may want to then go through that category of that list of supplementing the anesthesia. As I said, you know, you may want to give an intraligamental, and then ultimately, if that doesn't work, then you have to go into the pulp and say, right, you know, either extirpate it or do you prep it? Yeah, you just dress it. So you either prep or obturate it, or you just dress it. You need to make that call. Post-operatively, as I've mentioned, you'd reduce the occlusion. This is so the two cases I said, eukaryotic cases and fractured teeth. So caries is pretty obvious, okay? If you can see there's distal on this molar, you can see that there's some caries there. What you would expect to see clinically, once you've cleared the caries out, you can have varying degrees of bleeding, you know, in these pulpitic cases. So sometimes you'll have a mild to moderate bleeding like this, and you can actually see what you're doing. Once you irrigate that with some hypochlorite, you'd be able to see what you're doing. But in cases like this, for example, this patient had sensitivity for quite some time in this tooth, and then he ended up with acute toothache, couldn't sleep at night, couldn't bite on that side. And we thought, okay, when you looked at the radiograph, you'll see it's a lower 7. There don't appear to be, you know, many cracks or anything like that. I couldn't really detect much, but it was painful on bite pressure. It wasn't actually giving a response to cold at all. But I decided to go into the tooth. That's the root filling, by the way, and you can see that the occlusal surface has been reduced post-operatively. So I did this in most of the cases that I do are in a single visit. 95% of the cases I'll do are in a single visit. But you can see, again, when you assess it, as I said, it's a lower 7. Access-wise, is it difficult? the patient factors, he was not a very, from a communication point of view, as well as from a cooperation point of view, he was not easy. But you can, once I opened the tooth, when I accessed it, I told my nurse, Sakila, quickly get the camera on, because this is a good shot here. You can see I opened the tooth, and I was not expecting this at all. This is the extreme case of a inflamed pulp that you'll see, and it will ooze. You will get, there's a lot of pressure built up in there, and it will ooze like nobody's business. You cannot see inside the cavity at this stage. You cannot extirpate anything because you can't see where you're going. And you can see from the top left-hand side all the way down to the bottom, within the space of 30 to 40 seconds, I just about managed to get the camera on. The whole thing welled up, the whole dam welled up. And when you irrigate it, it still oozes out, and you have to let this go. You have to let it flood out. So this is probably the extreme case that you'll be dealing with. And until you can see what you're doing, don't consider going down the root canals. At this kind of stage, if you're not feeling comfortable and you can't see what you're doing, I would just put a cotton wool in there, put the lid on it after you've let it ooze for a bit, and then revisit the case, rebook them and revisit the case at a later date. This is the other variation of things that you can see in necrotic teeth, or partially pulpit, partially necrotic teeth. The top left-hand side you'll see is a necrotic case, but they still have pain at night. So we don't know what stage that pulp is in until you actually go in there. And if you look at the center picture, you'll see that in cases like that would have, if you put your probe in there and you have a quick whiff, you'll actually smell that it's infected, yet it's still vital. And when you actually go into that, they will still feel pain, particularly at the apex. You can see on the top right-hand side, there's a pulp that's been extirpated, and you can see it's necrotic at the base. But even that can cause even a tiny bit of pulp, like I'm talking about 0.5 millimeter of an inflamed pulp at an apex, can cause excruciating pain. Okay, so that begs the question: do you just put cotton wool in and with some leather mix in a cavity like this, or do you extirpate all the way? In the current some of the protocols that in some of the hospitals at the moment for this, during this COVID period, they're saying that you should just open and dress the tooth without even actually going too far into the pulp chamber. You were not told to extirpate it. I personally disagree with that. Depending on your skill level, you should be, if you're going to deal with acute care, if you're going to be dealing with acute care in this situation, you have to be prepared to go from any range of that spectrum with the understanding of what you're doing here. So I won't rant too much about, let's look at cracks. Teeth, a lot of the teeth, many people, I get referrals from many people who say, I can't see anything wrong with this tooth. It's a virgin tooth, there's no restoration whatsoever. But if you look at this premolar at the top, you'll see there is a crack, there does appear to be a crack line running from mesial to distal, but you can't see if it's actually going down vertically. When you take the lid off, when you access the tooth, you can see that actually that crack is across the top of the going right across the top of the roof of the pulp chamber from mesial to distal. And once you fully access it, you can see centrally there is some necrotic pulp in the actual pulp chamber. It did smell. This was a chronic case. And you can see there's actually a vertical crack, both mesially and distally as well. So here you have to explore the extent of the crack. If this goes into the root canal, then the prognosis and possible outcome is not going to be that great. So you have to factor that into your treatment plan. So do you continue, or do you actually say, right, close up and say this is probably better for extraction? Is going to be dependent on how far you see that crack going. And again, things like microscopes and any form of magnification will certainly help in these situations. Another case, again, completely virgin tooth, hot, cold sensitive. You can see that there's a crack on the buccal aspect of that tooth. You can see also there's a wear facet at the back, but sometimes you can transilluminate as well, and that shows up crack lines even better. Bruxism and occlusion are the two main things that will be causing this kind of a scenario. When I opened the tooth up, there were 3 mesials on this particular tooth. Lower 6 this is, yeah. So this patient was getting pain from both lower 6 and the lower 7. And we went for, I made a judgment call, and I said, I think at this time they were getting bite pressure from both 6 and 7. I said, let's go for the 6. I ended up doing the 7 6 months later because a different type of, or similar type of pain, but in a different tooth came back. So we ended up doing both teeth. And these are virgin teeth here. But have a look at the pulp chamber of the 6. You'll see there's sclerotic dentine. There are pulp stones in the actual pulp chamber. And that's a telltale sign that there is some occlusal trauma there, where the bruxism or whether they're bitten on something hard, but that's a long-term effect. So do look out for those signs. And as I said before, make sure that you can certainly deal with that. Another case of, can't remember what tooth this was. Yeah, lower 6, I think it is. Yes, another lower 6, completely virgin tooth, bruxist. You can see the radiograph here. So again, they've been bruxing for some time. If you look at the coronal aspect, you can see that there's a vertical line just in that mid-buccal area. And that's what I was first alerted to. And my nurse, who's quite astute and probably can teach a lot of dentists as well, that's the first thing she pointed to as well. And I thought, yep, I think you've got a buccal crack there that's going all the way probably to the pulp chamber. There's pulp canal sclerosis. You can see little white flecks in the pulp chamber. If you look further down, it's a complicated root, actually. It's a flattened root. But if you look, there's some condensing, there's some radio opacity at the tip of the mesial root. That's called a condensing osteitis, and that's indicative of the fact that this tooth has had chronic irritation. So this has been going on for quite some time. Okay, when you open the tooth up, the actual crack was on the distal ridge. Okay, so again, it's sometimes what you see on the X-ray or what you see clinically can be deceptive, and when you open them up, you can then explore the cracks further. That's just a completed endo. You can see I've got sealer out the tip of the distal canal there. The Americans like it. Some people in Britain like it. In Britain, we tend to keep everything in the canal, which is actually probably a better option, particularly in pulpitic teeth. Okay, so you can instrument to length, but if you're going to obturate, preferably obturate short. When I say short, within 2 millimeters, but or right on the actual apex, because the excess sealer can cause irritation to the cut end of the nerve externally, and these kind of cases can take time to settle. On that note, something that has a chronic pulpitis like this that's turned acute actually will give you more postoperative sensitivity for a longer time. So do make sure you warn your patient this can be sensitive. When I say sensitive, not thermally sensitive, but it can be sensitive to bite. And very often you'll have patients that come to you and say, you did this root treatment, it all looks fine. You know, I'm still getting sensitivity when I push the tooth. And this is like 2 months on. Okay, that is a neurogenic type of inflammation that's going on at the tip. And that's quite common. It will settle with time. Again, note occlusal reduction. You can see, look at the cusps. I've taken the cusps out. I've taken it out of occlusion to actually help the healing process and prevent any further cracking prior to the crown going on. So lastly, I'll conclude with this case. Just have a quick look at this upper right premolar. If you looked at this case and given what I've said, and when you're assessing cases like this, you've got the challenges here. You've got a crown. It's a long-standing crown that was probably leaking because it had been there for about 15 or 20 years quite successfully. And all of a sudden, this patient turns up in pain. And they say, look, I've got this toothache. I can't, hot and cold, I can't take. It didn't keep him up at night. But when you look at the tooth, you say, what are you going to do in this situation? Depending on your skill set and your knowledge. I mean, you look at the X-ray. If you look at the roots of the tooth, you can see that they almost like ghost-like, they disappear. So that should alert you to the fact that there's possibly more than 2 roots on this tooth. Okay, if you look at the actual post-op, you'll see, and it's a 3-rooted premolar. But when you cut through these crowns, it can be very difficult to see where you're going. And to do a case like this, you definitely need magnification and sometimes more importantly, illumination. So do consider each case on its individual basis. Going back to my initial slides of, when you're assessing a tooth, you must look at your factors, your skill set and your knowledge, patient factors and your local factors, whether you have the equipment, before you decide on doing these kind of cases. And that is what I will conclude on. I hope that was useful for you, whichever sort of line of work that you're in. And I think we're going to have now a presentation by Dr. Rawalia, who's going to talk about some alternative therapies. And no doubt, if I've missed anything or you have any questions,